the question they were asking was, as a pharma company have done very well in going from regular insulin and flattening it so that the peak over trough is much lower than it was. But how low is good? How low do I want to go? Does it gain any advantage for me to go below a peak over trough of 1.5? So, we developed a model to try and answer this question. So, we first came up with a structure, developed a model, came up with the right parameterization, came up with a bunch of patients who behaved appropriately under other insulins. So, this is called a model calibration process. So, we are set, we know we believe this model, because this model behaves appropriately when you give the existing insulins. Then we said, okay, these two are the existing insulins, these three are the insulins we want to try. So, the existing insulins are kind of peaky, but they are still pretty good. Does it matter if I change the pK to something flatter and flatter and flatter? How much advantage will I get? That is the question. So, now we have all the way from the pK to the PD, we know what the HbA1c, what the glucose is, everything we have covered, using a model like this. Like we discussed, why do we want to make, what are the two things we want to make sure when we give a person a drug? What are the two things we want to worry about? We want to worry about efficacy, which is if you are a diabetic, if your sugar is high, we want to make it low, but we want to also worry about safety, and we want to make sure we do not get it too low. So, balancing safety and efficacy using the pK is what we are after. So, then we said, generally for a lot of drugs, and even in our case, as you increase efficacy, so this is how much glucose are you lowering. This would be a completely useless drug, it does not lower glucose at all. This would be an extremely effective drug because it lowers the glucose a lot. This is the threshold. You at least want to lower the glucose that much for it to be an effective diabetes drug. So, as you increase the efficacy, what usually happens is the safety decreases. So, as you decrease glucose, you increase the number of hypoglycemic events, which you do not want the patient to have. You do not want the patient to feel faint, you do not want the patient to lose control, but what you see is in general, the harder you push on efficacy, the more safety events you see. This is for a normal insulin which already exists. Now, you make the pK a little flatter, your curve characteristics start to look better. You are able to get the same efficacy for a lot less safety events. So, this guy is seeing 4 fewer events. So, that is great, you are on to something. So, what happens if you lower it more and more and more? That is the question we asked with the model. So, after this it is all just modeling and simulation, this is not data. Then we see that yes, there is some effect to be gained, there is some more effect to be gained, but the effect is saturating. If you want to spend $1 billion to make a drug, it's not going to keep on increasing in its efficiency. There are limits that you're going to get, and that's what the model says. Most of the advantage that you get in changing the pK by reducing absorption, it's promising, and it was important to push on it the past few decades, but now the more you push at it, you're reaching this part where you're really not going to see a lot of advantage. So, that's what we're able to kind of say as a first order response with modeling and simulation. There's more to it, more subtle questions you can ask. How much insulin does the liver see? How much insulin does the muscle see? How does that affect the patient? Does it help the patient be more consistent with their dosing? There are a lot of things you can ask, and we did more work on that as well, but this is a quick result. Yeah.
So, can we try combination of drugs such that some drugs will take care of the safety and the insulin supplement will only take care of the efficacy, such that we can push that boundary a little further?
Yeah, that's a very good question. A lot of people try combination therapies for exactly that reason, to push efficacy while managing safety. Diabetes is an interesting case because safety and efficacy are almost the exact same thing. You want glucose not to be low. So, for instance, in autoimmune diseases, for example, it is possible, it's potentially possible that you can reduce the overall inflammation, but still be responsive to infection. So, that is a side effect, right. So, when somebody has arthritis, their immune system is too inflamed. So, you want it to calm down, but the immune system has a role. When you get a bacterial infection, you still want the immune system to respond. So, for things like that, you can kind of titrate it better. For diabetes, it is a lot harder because it is the exact same thing. There is only one axis that you have.